Good morning, everyone. For this new episode of TransConnect on diagnostic modality for syphilis, that is the TTI, which we encounter so often in our testing. So everybody is doing the VDRL test or an RPR test or a CMIA for the same. And in transfusion medicine, it holds importance because it is one of the 5 mandatory tests that you have to do. This is TransConnect June 2023. I am Dr. Mohit Chaudhary. I am a senior consultant in transfusion medicine in New Delhi, and I am accompanied with me my colleague Dr. Rashmi Jain. So today we'll be talking about syphilis and the testing involved with it. The overview of the same will be brief account of the disease course, the concern in the field of transfusion medicine, and understanding the diagnostic modalities associated with it. So syphilis, we all know, is caused by Treponema pallidum. Nearly all contacts are through the sexual contact with infectious lesions like chancres, mucus patch, skin rash, or condyloma lata, which is a secondary syphilis. Less common modes of transfusion are non-sexual skin contact, infection in utero, blood transfusion, and organ transplant. Here we are worried about these two, blood transfusion and organ transplant, which involves us. Globally, there are 6 million cases of syphilis and new cases of syphilis annually in person aged between 15 to 49 years occur very often. There are 3 lakh fetal and neonatal deaths that are attributed to syphilis, with an additional 215,000 infants at increased risk of early death. So it is a problem that we all know of, and we need to cater to the response and the testing that we perform in our lab. So what is the clinical course of syphilis? Generally, it is, like I said, is a sexual contact with the infectious lesion, and it makes hard chancre, and this is a primary syphilis because it is a single painless papule. Now there are stages of dissemination. Then we move to the secondary syphilis, which gives you a rash or a wart-like condyloma lata, which is a mucosal patches and systemic manifestation may occur. From there, 30% of the patients may have a spontaneous resolution, whereas 70% of patients may show some latency. Early latency is when 30% of patients then have a serofast reaction, and late latency in which 40% of the patients have serofast reaction. Finally, the tertiary stage of syphilis, where we have the cardiac and the CNS complication along with the gammas. So this is the pictorial representation of various stages of syphilis. You can see the early neonatal, you can see the primary syphilis, and you can see the secondary syphilis. Yeah. Now moving to the syphilis in transfusion medicine. For this, I would like to call upon my colleague, Dr. Rashmi, who will be taking you further in this episode.
So, continuing forward, I'll be discussing about why syphilis is important in our field and how do we diagnose this syphilis, the laboratory workup for this disease condition. So, in our field, this could be transmitted through the fresh blood and platelets. Platelets, as we know, being stored at 20 to 24 degrees Celsius, they provide a very hospitable temperature for Treponema pallidum. However, it cannot survive for a longer time at a high oxygen tension as in modern platelet storage bags. There is no transmission noted by the plasma products fraction from the pooled plasma. Now, if we see in today's era, there are multiple reasons which has led to the decline of transfusion transmitted syphilis, and these are as follow. The implementation of the universal donor testing, and of course with the advent of the antibiotics penicillin, there is a decrease in the prevalence of the syphilis in many countries. And last but not the least, universal practice of storing blood at 4 degrees Celsius before transfusion. So, coming to the WHO donor selection guidelines, whom we should accept as a donor, whom should be deferred, and whom should be permanently deferred. So, all the household contacts of individuals with the syphilis can be accepted. However, those who are the current sexual contacts of individuals with the syphilis, or those who are the former sexual contacts of the individual with the syphilis, should be deferred. The latter, that is the former sexual contacts of the individual with syphilis, should be deferred for the period of 12 months since the last sexual contact. And those individuals who have ever had a diagnosis of a syphilis should be permanently deferred. Now, coming to the laboratory diagnosis of syphilis. Historically, if we see, serological aspect has formed the main diagnostic methodology. However, it has come with the issues with the lack of specificity, especially of the non-treponemal test, and a poor correlation of the treponemal test with the disease activity. Therefore, the results should always be interpreted in conjunction with the additional treponemal or non-treponemal serological test in conjunct with the patient's clinical symptoms, medical history, and other clinical or laboratory findings to make an appropriate diagnosis of the syphilis by stage. As per CDC, that is the Center for the Disease Control and Prevention, Sexually Transmitted Disease Treatment Guidelines 2015, treponemal and non-treponemal tests should be used in conjunct for making an appropriate diagnosis of this condition. So we'll be focusing more on serological tests. Serological tests can be divided into two categories, non-treponemal test and treponemal test. Non-treponemal tests which are commonly employed are the VDRL, Venereal Disease Research Laboratory, and RPR and TRUST, which is not commonly used in Indian setup. Treponemal test includes the fluorescent treponemal antibody absorption, treponemal pallidum particle assay, treponemal pallidum hemagglutination, MHTP, CLIA, CMIA. There are other methods which can be used for making a diagnosis of syphilis, which falls under the category of direct detection methods, which where the sample specimen is being taken from the lesion, which could be skin or any mucosa or exudates, and it could be subjected to dark field microscopy, or it could be specialized stainings, histochemistry, immunohistochemistry, and we can do the PCR for the same. Coming to the non-treponemal test, these are being performed on serially diluted serum so that we can detect the total antibodies, that is IgM and IgG, directed against the lipoidal antigens like cardiolipin and lecithin. These are being released from the damaged host cells and the bacteria. These antibodies are non-specific and they usually are not detectable until few weeks after infection. Non-treponemal tests are mostly quantitative and they are being reported in titers. Qualitatively can also be done, used to monitor the disease activity such that if there is a fourfold or greater decrease in the follow-up titer from the baseline titer in parallel using the same assay. So, non-treponemal test, this is useful for diagnosis of reinfection or relapse, as it can be highlighted by a fourfold or greater increase in the titer. Then, a very important thing which is to be noted while taking the non-treponemal test is they cannot be interchanged. Like if you're using a VDRL for making a primary diagnosis, then for follow-up it should be used VDRL, or vice versa, RPR, and preferably in the same laboratory. Now, coming to the individual test, that is the VDRL. The principle is it is a microflocculation test which helps in detecting the antibodies in the patient's sera against the reagent, that is an antigen which is formed by a combination of a cardiolipin, lecithin and cholesterol. So it is come as a specialized kit which consists of a card where individualized circles are there and there is a negative and positive control with the reagent. The reagent in this has to be prepared daily. That is one of the drawback of this method. And in this, we are going to add the specimen and then we'll add the reagent, and simultaneously we'll be doing the same for the negative and positive control, and we'll be noting the results. This test can be done qualitatively as well as quantitatively. Quantitatively will give us the titers. So coming to the interpretation of the results, if we are seeing the microfocules which are in large or medium quantity under the microscope, then it is being regarded as a reactive test. If there are small microfocules observed under the microscope, then it is called as weakly reactive. However, there are no microflocule formulation against the gray background, then it is called as the non-reactive test. The only drawback of this test is it requires a microscope for interpretation of the results. Coming to the second non-treponemal test, that is RPR. This is a macroflocculation card-based test which uses the same antigen as VDRL. However, There is an exception, that is, it is bound to a carbon particle and uses a charcoal particle as a visualizing agent. This is the most commonly employed non-treponemal test in majority of the laboratories. Again, it can be done qualitatively as well as quantitatively. The advantage of it over VDRL is that we do not require a microscope for interpreting the results. Coming to the test procedure, so here we can appreciate that it is a kit which comes with the reagent, positive control and negative control. We are going to add we are going to add the reagents and the positive and negative control on the respective wells, and to it we'll be adding the sample, then and we'll mix it nicely, and then we'll allow it to rotate using a shaker for about 8 minutes at the speed of 180 rpm, and after that we will interpret the results. So as per the results, so again, if the large and medium microflocules are formed against the white background, it is regarded as strongly reactive. If small microflocules are being formed, then it is being regarded as weakly reactive. Then if there are no macroflocules formation, then it is called as the non-reactive test. Coming to the last non-treponemal test, that is the trust, which is not commonly employed. However, it is similar to RPR, and it uses toluidine red as a visualizing agent instead of charcoal, and sensitivity wise it is similar but slightly better in terms of specificity. Coming to treponemal test, these are qualitative assays which are performed on serum to detect the antibodies against a variety of treponema pallidum antigens. These antibodies are detectable by 2 to 4 weeks after the exposure, and it typically is being reported as a reactive or non-reactive without any titers. These are in general more sensitive in case of early infection, and once positive, so they will usually remain reactive indefinitely. Hence, we cannot use treponemal test for monitoring the treatment response or making a diagnosis of reinfection because of the poor correlation with the disease activity. Secondly, we cannot distinguish the syphilis from infection with the endemic species like Treponema pallidum subspecies pertone or Pintana due to the cross reaction. Now, coming to the treponemal test, that is the fluorescent treponemal antibody absorption. It is an indirect immunofluorescent assay which involves the pre-treatment of serum with an absorbent, usually an extract of a non-pathogenic treponemal species, that is the phage dennis, which is used for removing the potential non-specific cross-reactive antibodies from the test serum. Dilutions of the test sera are added to the slides, which are dotted with the fixed organism from an extract of Treponema pallidum, that is the Nicole strain culture. Then fluorescent conjugated anti-human immunoglobulin is added, and it is added to visualize the antibody labeled organism. The test usually takes 1.5 hours to complete. However, this is not being recommended as a routine screening test because of the subjective interpretation, inability to automate for large specimen number, and the requirement for the fluorescence microscope. And non-specific reactions, if we see, it can give a false positive result as well. Coming to other tests, that is the microhemagglutination assay, Treponema pallidum hemagglutination assay, and the Treponema pallidum particle hemagglutination assay. If we see MHA and TPHA, these are manual indirect hemagglutination assay which are being performed in a microtiter plates utilizing the sheep and fowl erythrocytes which are being sensitized with the Treponema pallidum antigen respectively, and these agglutinate with the anti-treponemal IgM and IgG antibodies. Serum is first mixed with the absorbing diluent which is made from non-pathogenic species, that is the writer treponemes, and other absorbents are being there so that it can reduce the potential risk of false positive reactions. Serum containing the antibodies are going to cross-link with the red blood cells, and they will form a smooth mat on the base of the well, which is being appreciated as the formation of the hemagglutination, indicating it as a positive reaction. Another test, that is TPPA, that is Treponema pallidum particle assay. It utilizes a gelatin coated particles with the Treponema pallidum antigens, and it is combined with the patient's serum. If results in clumping, then it is being regarded as a positive test. It is to be noted that TPPA has replaced both MHA-TP and TPHA because of better sensitivity and comparable sensitivity to the that is fluorescent treponema antibody absorption. It is also performed in microtiter plate, and it typically requires a minimum 2 hours of incubation. TPPA, if we see, it is easier to perform and it is less prone to non-specific reaction because by using the sensitized gelatin particles instead of the erythrocytes. And unsensitized gelatin particles are being used as a control for non-specific agglutination in this test. Compared to the FTA ABS, this is has got a comparable sensitivity. However, it is less expensive and complicated. So the results are majorly importantly, we can appreciate the results with the naked eye. Coming to the another test, that is anti-treponemal IgM. This can be served as an indicator of recent infection, especially in case of adults and in neonates. After the treatment, if we see, IgM usually declines by around 4 months, but it can remain elevated longer if disease remains untreated. So the importance is, if we are detecting the anti-treponemal IgM, then it is largely confined to selected cases specific to the diagnosis of congenital syphilis. The methods which can be utilized for anti-treponemal IgM includes the FTA-ABS IgM, enzyme immunoassay IgM, or immunoassay blot. A reactive anti-treponemal IgM can indicate the presence of active syphilis. However, we cannot preclude the possibility of chronic infection because there could be a prolonged release of IgM antibodies. Further, if it comes out to be non-reactive, then we cannot exclude the recent infection as well. Coming to another and the most important test, which is now most commonly used, is the CMIA, that is the chemiluminescent microparticle immunoassay. It is a two-stem immunoassay for the qualitative detection of the antibodies, that is IgG and IgM, which is directed against the Treponema pallidum in human serum or plasma. The basic principle is the presence or absence of anti-TP antibodies in the specimen is going to be determined by comparing the chemiluminescent signal which is being generated in this reaction to that of the cutoff signal which is determined from an active calibration. It is being provided, this is being done with a specialized laboratory setup, and these come with a specialized kit. So the kit which is used for detecting the syphilis consists of the enlisted items, which includes the microparticle, that is the TP antigen, E. coli recombinant basically, that is coated microparticles in the HEPS buffer with the detergent. Then we have the conjugate, which is a murine anti-IgG or anti-IgM acridium labeled conjugate in MES buffer with the protein stabilizer. We have assay diluents, that is the MES buffer with the detergent. We have pre-trigger and trigger solutions. Pre-trigger solution is 1.32% weight by volume hydrogen peroxide, and trigger solution is 0.35 normal sodium hydroxide. And yes, of course, the wash buffer is also there, that is the phosphate buffered saline solution. So coming to the method of performing the CMIA, we are going to combine the sample assay diluent and the recombinant TPA antigen coated microparticles. To it, anti-TP antibodies are going to be present in the sample. So it binds to the TP coated microparticles. Then it will be subjected to a washing. After washing, anti-human IgG and IgM acridium label conjugate is added to create a reaction mixture. Then another cycle of washing is being subjected, and after that we are going to add the pre-trigger and trigger solutions to this reaction mixture, and we will analyze the result. So the resulting chemiluminescent reaction is going to be measured as RLU, that is the relative light units. there is a direct relationship between the amount of anti-TP antibodies in the sample and the RLUs which are being detected by the architect system, by the system. So coming to the result, we are going to calculate it using the ratio of the sample RLU to the cutoff. So cutoff RLU is being calculated as calibrator mean RLU multiplied with 0.20 factor, and then we are going to take a ratio, that is the sample RLU by cutoff RLU, and we are going to interpret according to the values which are being noted. In case if it is less than 1.00, it is being regarded as non-reactive for treponemal antibodies, and if it is more than 1.00, it is being regarded as the reactive for treponemal antibodies. So, what are the limitations of the CMIA? It's the kit itself comes with the limitations, and it says that we need to do the serological testing in conjunction with the full clinical evaluation, and any kit which is being there can give us the false reactive results. And in case if it is a non-reactive treponemal test, then it does not exclude the possibility of exposure to or infection with syphilis, and in fact antibodies may be or at low or undetectable levels in the incubating phase or in early primary disease or in some clinical conditions. So in such cases a parallel testing is recommended. And in other words, if the patient is a immunosuppressed patient, or the sample is being obtained from patient having disorders leading to immunosuppression, then the results should be interpreted with caution. uh, Second, lastly, the test cannot distinguish between the active and treated infection. Last but not the least, it can be interference can be noted due to the circulating antibodies against the non-pathogenic species of the Treponema pallidum, because these are not being evaluated and cross reactivity is expected in such conditions. So, coming to the diagnostic algorithm for the serological diagnosis of syphilis, there are two algorithms. Firstly, traditional algorithm and the reverse algorithm. So, coming to the traditional algorithm. So, in this algorithm, we are going to do the primary evaluation of the sample, or what we call a screening, using a non-treponemal test as discussed, VDRL or RPR. In case if it is being found as reactive, then we need to confirm by using the treponemal assay. However, in case it is non-reactive, then it is being no further thing has to be done. So important to note that we are going to do the follow-up using the we are going to do the follow-up using this non-treponemal assay, which ensures, importantly, as I mentioned before, the same non-treponemal test should be used, which for follow-up, which we have used while making a diagnosis or making or while screening. It is being done at 6 months. This test is being repeated at 6 months, where we are going to look for a four-fold fall in the antibody titer for the follow-up, providing the treatment to the diseased individual. And importantly to note that treponemal assay, which I'll be discussing subsequently, then reverse algorithm, which forms as the main first primary test for in reverse algorithm. So these treponemal tests are not being preferred for follow-up, because they remain positive for years after even completion of successful treatment. Let's take a look at the benefits and limitations of the traditional algorithm. In terms of benefit, it is a very cost-effective methodology for screening, and it is suitable for a resource-limited setup and low-volume laboratories. However, it comes with the limitations of lack of specificity, manual operation, and subjective interpretation. Now coming to the second algorithm, that is the reverse algorithm. Here the primary evaluation of the sample or screening is done using the treponemal assay. That is, in case it is found reactive, then we are going to confirm it using the non-treponemal assay. Again, if it is noted as reactive, then it can be regarded as syphilis being present in the past, or it could be a newer case of syphilis. In case if the discordant result is obtained, that is a non-reactive result is seen, then we are going to subject the sample to a second treponemal test, which is usually a treponemum pallidum particle assay. And if it is reported as reactive, it is being considered as syphilis in past or new case, or if it is non-reactive, then syphilis is unlikely. Indeed, if the primary evaluation comes out to be non-reactive, then no further evaluation to be done. Now, let us see the benefits of reverse algorithm. This is very much beneficial in case of the high through output laboratories, and it is less labor intensive and it is more efficient with the rapid turnaround times. It allows the detection in the early disease. However, the only limitation is the false positive in low prevalence population. However, we can overcome with this limitation using the second treponemal assay as the confirmatory test. So coming to the inference, we can conclude that serological diagnosis and exclusion of syphilis in most of the suspected cases with high clinical probability will require the collective results, both from treponemal and non-treponemal tests. Sensitivities of both the tests are dependent on the stage of the disease, such that treponemal tests are more sensitive in early disease and non-treponemal tests are less sensitive in early and latent disease. So non-treponemal tests should be used for the monitoring the disease response or follow-up following the treatment of the patient. Now, last but not the least, the clinical context should always be considered, especially in the high risk group individual, in order to pretest the probability of the disease. So, coming to the conclusion, diagnostic workup involves the clinical correlation in adjunct to the serological testings. Thank you.